Good evening, everyone. And thank you so much for joining us for Communities Are Our Best Defense. I'm Molly Rose Kaufman, a member of the People's CDC and the director of the University of Orange, a free school in Orange, New Jersey, dedicated to education for equitable cities. The People's CDC is a coalition of public health practitioners, scientists, healthcare workers, educators, advocates, and people from all walks of life. We formed just over a year ago on January 13th, 2022, when a call was issued that said, under both the Trump and Biden administrations, the CDC has repeatedly bent the science of COVID against a full spectrum response, and increasingly with the aim of sending millions back to work and school under what have proven to remain dangerous conditions. That kind of anti-public health approach is unacceptable. What does a people's response to such a dereliction of public health duty look like? Join our panel of epidemiologists and community leaders for a discussion of what an exit out of the COVID trap requires. Help set up working groups to push for specific interventions that are proven to help control both the COVID outbreak and mitigate the burdens that arise from these intercessions. Despair alone is not an option. We need to act. Over the past year, our teams have done remarkable work, starting with the belief that sharing accurate, accessible information is an essential form of mutual aid. This evening, we'll begin with a COVID This Week presentation with Dr. Rob Wallace, followed by a presentation by Mary Germanis and friend of the People's CDC, Adam Moore, about organizing around COVID safety during the UC graduate student strike. We will then hear from our teams about their accomplishments. This will be followed with some time for questions and answers. I'm sure you will leave feeling a deeper appreciation for the meaning of tonight's title, Communities Are Our Best Defense. So now I will turn it over to Dr. Rob Wallace.
I need to unmute myself, as one needs to do. Hello, everybody. It's wonderful to be here. And I am an evolutionary epidemiologist. I'm at St. Paul, Minnesota. I'm going to talk a little bit about the state of COVID as it is presently. I'll talk about the state of global COVID, the state of US COVID. On our usual broadcasts, we also do a special topic. So for instance, we've reported on the impacts of long COVID on health and the economy, the way COVID is being positioned as a weapon in the kind of global rivalry between the US and China, and what Damar Hamlin's collapse on the football field might say about COVID's impact on young people's hearts. But in the interest of time, I'm just going to talk about where we are with global COVID and US COVID. Next slide, please. Thank you very much. We begin with global COVID. There in the graph in red, the Johns Hopkins Coronavirus Resource Center reports us at 2.6 million new confirmed COVID cases worldwide for the week ending January 15th. The number of global weekly deaths there in white is up to over 16,300 confirmed deaths this past week. In green, we see global vaccinations up to nearly 63 million administered for the week. Next slide, please. This New York Times map shows hotspots over the past week. In the Western Hemisphere, the US and Costa Rica are at the highest in cases per 100,000 population. Europe is reporting a retraction in caseload, although it still remains a global hotspot. Japan, South Korea, and New Zealand remain top-tier hotspots. Next slide, please. As we see from these percent changes in caseloads the past couple of weeks, rebounds there in the warm colors are still scattered across the globe. In the Western Hemisphere, Canada, Nicaragua, Jamaica, Haiti, and Guyana have heated up. Europe appears cooling, but we see Ireland and UK flaring up, and we also see increases in Belgium and Eastern Europe. Iran and Mongolia continue in their series of intermittent bursts, and Thailand continues to be showing a large increase. China appears cooling off from its New Year peak after a burst of cases killed 60,000 people since early December. In Africa, Zambia, Mozambique, and other countries in the south are hosting increases, as well as farther north, Sudan and Kenya. Next slide, please. Here's the Containment Health Index. It offers a measure of the combination of non-pharmaceutical interventions that countries are pursuing, things like mask mandates, testing, and contact tracing. This is still the same data in terms of where we were at the end of the year, but we have more countries that are reporting in. Despite ending its version of zero COVID, China is still setting the pace here, followed by Zimbabwe and Iran. But for the most part, many countries have basically stripped back those non-pharmaceutical interventions. Next slide, please. And this is all going on at a time when the vaccine strategy that many governments saying are going to replace those non-pharmaceutical inventions are largely failing. So much of the world is at best vaccinated for variants that are no longer circulating. And we see uneven campaigns around the world in terms of the booster vaccination. So on the one hand, we have Chile, Peru, Uruguay, Cuba, Canada, Belgium, Finland, Germany, Italy, Australia, and Japan are displaying top-tier booster campaigns with 70 or more people boosted per 100 population. In contrast, we see near nothing in Russia, India, Pakistan, Indonesia, and those even reporting in from Africa, as well as mediocre campaigns, though it's not shown here, includes the US, but also Mexico, Brazil, China, and Eastern Europe. The CDC does report that the US is a little over 15% of its eligible population 5 years and older are up to date on their booster shots. Next slide, please. So the collapse in vaccination or kind of scaling back is kind of hand in hand with, which goes hand in hand with the kind of rollback in non-pharmaceutical campaigns. You need good non-pharmaceutical campaigns that have good vaccination campaigns. But this is all going on at a time in which multiple Omicron subvariants are circulating across large expanses of the world. And so here we have, as of January 16th, in some of the countries that are reporting in their COVID samples. And of course, this is largely biased to more high-income countries. BA5 in blue still dominates in France, the Netherlands, South Korea, and China, but is falling farther back as BQ1 in salmon and XBB in purple are coming on stronger. Next slide, please. Now, China's new outbreak has been presented in the press as if it's a grand mystery, but real data are emerging, including subvariant sequences by province, as Daniel Focasi and Federico Guelli show here. So we see new sublineages BA 5.2.48 in red dominates in the south, and BF 7.14 in blue largely in the north. But many other subvariants are in play, and it kind of offers China as a kind of reflection about what's going on here in the US. Kind of vast laboratories in both places in which a variety of Omicron lineages are newly evolving and recombining. Next slide. Now, as we've described in previous COVID this week's, we have David Ho's team shows that one set of recombinants, XBB and XBB.1, they are in the red box on the left. Well, it's not there, but it's over here if you can see my pointer there. It's all along here, it shows that it's resistant to the kind of monoclonal antibody treatments, and the resistance can be shown across the different parts of the receptor binding domain of the spike protein there. Next slide, please. So along with mutations that allow resistance to monoclonal antibodies, we are finding mutations that are emerging that are resistant, providing SARS-2 resistance to Paxlovid, the antiviral medicine there. And this is showing up in various sequences that are showing up in various sequence databases, but also as well as in patient cell cultures. So, you know, letting COVID rip also allows COVID to rip back through all the tools that the Biden administration and other administrations around the world have repeatedly referred to as the end of the pandemic. Next slide. Turning to the US, we see from the Walgreens COVID-19 index that as of January 16th, national test positivity is still over a third positive for both rapid tests and PCR, but we also see a decline over the past week. Next slide, please. This New York Times map shows COVID cases per 100,000 population. Spatially, the national caseload looks rolled back from mid-December. We see caseloads seemingly peeled back from that kind of northwest corner all the way through the upper Midwest and down to the Southwest. But in the South, we have from Texas all the way through Virginia, remains very much hit, particularly West Texas, Southern Oklahoma, Mississippi, Alabama, West Tennessee, Kentucky, now again, the Carolinas, and much of West Virginia and Virginia. Florida is showing itself newly hit, and the tri-state region around New York City remains an epicenter. And now we have Puerto Rico and Alaska are also hosting outbreaks. Next slide, please. There are other modes of tracking how COVID-19 is doing, and we need to look at them as kind of the reporting starts to decline from state to state. So we have COVID-19, however, this is going to be patchy for these other ways. So we're looking at SARS-2 detected in the wastewater that goes through our sewage plants. In some ways, something of a leading indicator of the pandemic. But here for January 1st through 15th, we see other than Oregon, Missouri, and the Michigan-Indiana border, and upper New York State, most of the plants reporting in fell into plant levels of 60% or more as calculated since December 2021. So they're in the orange and red. Next slide, please. There's also a more acute measure in terms of the changes in sewage loads over the past 15 days. And perhaps that shows more easily kind of transient dynamics, things that are happening recently. And we see for the first couple weeks of January, a much more nuanced mosaic of plant results with, for instance, in the Bay Area, Southern California, Colorado, Wisconsin, Ohio, and New York State, a kind of mix of plants that are in sharp increase and others that are cooling off. Next slide. So to kind of sum up things a little bit here, here's the PCDC version of our present community transmission by county as of January 12th, as mapped by our own Les Schaefer. The map shows the kind of combo of caseloads and test positivity that the CDC plots, although they're reporting it only once a week now. But unlike the CDC, the PCDC differentiates the high level of danger counties are subjected to beyond 10% COVID positivity into high, very high, and extremely high exposure. And down at the bottom there, there we go, down at the bottom there, we also have the PCDC differentiates exposure by both the percent of counties and by the percent populations. So overall, we see a contraction here in the US. We see the kind of peeling back we previously discussed from the Northwest eastwards into the Dakotas and southward to the Four Corners. Although that's filled in again since late December. We see some areas still very much epicenters, including West Texas, Oklahoma, West Tennessee, Alabama, the Carolinas, Virginia, and the New York City metropolitan region. Regardless of these geographical shifts, by population, the US remains in full bloom. We're at 84% plus of the American people in communities subjected to high to extremely high COVID exposure, with another 11% plus subjected to substantial exposure. Next slide, please. The outbreak also continues to evolve. So here we have the explosive emergence of XBB 1.5 that we've discussed at COVID this week, last week. BQ1 and BQ 1.1 are also still strongly represented. Next slide. Although that is also entirely dependent on place. So here's the 15-day trend of all the genetic sequences of detected sublineages in the US as of January 18th, including their geographic origins. So XBB there, 1.5 in blue, BQ1 in gray, and BQ 1.1 in red are competing with each other as far as the new sequences that are added to the database. And we have BQ 1.1 surge in the past week, maybe due in part to the kind of large data sets that are coming in from Texas and North Carolina. But still, as we saw at the international level, multiple subvariants and sublineages are co-circulating together in the same locale, likely increasing the chance of the kind of genetic recombination that allowed XBB to emerge in the first place. So what we're getting at here is that driving down COVID-19 would be much better in terms of cutting off the capacity of the virus to be able to evolve into all sorts of new directions, including resistance to our drugs and our vaccines. Next slide. Where's that? Okay, yes, that's the end for this week's COVID This Week. But you can find all our COVID This Week episodes on the PCDC YouTube channel. And so that's it for now. I'm going to hand it over to Mary and Adam, who are going to be talking about an example in which community intervention can help stop the spread of COVID, in this case, during an academic strike.
Hi,
Thanks, Rob. Go ahead, Mary.
can people see us? Okay. Hi, I'm Mary Germanis Sava. I am a geographer and a filmmaker and a member of the People's CDC. I'm also finishing my PhD right now at UC Berkeley. I'm also a member of UAW 2865 and the new union UAW Student Researchers United.
And I'm Adam Moore. I am also a PhD student and I am at UC Davis, and I am an infectious disease epidemiologist and microbiologist. And yes, as Mary said, we are both members of the United Auto Workers Local Chapter 2865 and the newly formed Student Researchers United. And so today, like Rob introduced, we're going to be talking about COVID safety and disability justice as it happened during our strike. And just to give everyone a bit of background, if you hadn't heard, from November 14th until December 24th, or December 23rd rather, around 48,000 academic workers were on strike across the University of California system for unfair labor practices from the University of California while trying to negotiate a new contract. And our story actually starts a little bit prior to the strike. It starts in the fall of 2021 at UC Davis when fall quarter was starting and the university had rescinded a lot of COVID protections that were in place. And so union members filed a grievance with the university to try and get some of these back into place, especially, and this work was led largely by disabled workers because we know disabled people are at high risk for COVID. And so this was a very long process, and the union officials actually settled this grievance without the input of rank and file members, and we didn't get any new protections. And so that leading into the strike, COVID safety and disability justice were on the forefront of a lot of disabled workers like us, our minds. And so as the strike is about to begin, we are figuring out how we can promote COVID safety within the strike and within the union. And we were inspired by other examples that we saw across the country. A faculty union at Rutgers was able to secure a mask mandate when the university tried to rescind it. And then we also saw federal judges side with many disabled students across the country, actually particularly in states that are usually pretty red, in favor of requiring masks in the classroom as a protected accommodation under the Americans with Disabilities Act, or the ADA, which led us to conclude that these mask bans are actually illegal. This is a reasonable accommodation that disabled people have the basic right to. Next slide, please. And so we wanted to get the word out about COVID safety on the strike. And so this started not necessarily through official union channels, but we created flyers about basic COVID safety and disability justice as a whole. And we started sharing them on the picket line, on social media, in group chats, email blasting people, just trying to get this information into people's hands, because this was taking place in the fall as a surge was beginning, particularly in California, in all of our UC cities. And so we were trying very hard just to get people the right information so that they could stay safe, because we didn't want workers getting sick and then weakening our movement because they are unable to participate in the strike itself. And so at first it was a bit piecemeal as we were just figuring out what we could possibly do. And a lot of this information was informed by a variety of resources that were coming out of the People's CDC. So like their layers of protection document, the Safer Gatherings Toolkit, and the weekly weather report. We were sending these to people regularly to inform them like, hey, this is the COVID transmission in your area, and these are basic steps you can do to keep things, to keep yourself safer and to keep those around you safer. Next slide, please.
So as Adam said, we saw the problem at hand. We started to understand in consultation with sort of various advocates and also lawyers. I'll say one of the wonderful and very helpful people who disability justice and disability justice advocate and disability lawyer, Pantea Javidan, is also here in attendance, met with us and discussed kind of what we could do and really affirmed the fact that our instinct that mask bans were and are blanket masking bans are illegal. So, you know, we wrote a letter, we wrote an open letter, which you'll see in a second. And the open letter was under the title Disability Rights Are Worker Rights. And we started to send that around even within just very small networks for signatures. And then we basically got maybe around 100 signatures pretty quickly through our networks, our already existing networks. And you know, then we asked for a meeting with the union. We went and we sort of kept asking them, we kept saying, you know, we really want to add this, we want to create a new article. We know that the strike is basically about to start. But we need to create this new article about COVID safety. And they told us no. And they gave us a bunch of reasons. And they said, actually, it's illegal to add a union, to add a new article to the slate of negotiations at this point in the game. And so basically we didn't take no for an answer. We went and we consulted with some labor lawyers, and those labor lawyers told us, actually, this is a political question. It is not a labor law question. If you have the power to force a new article on the agenda at this late game, at this late stage, then you can do it. You can do anything that you want if you have the power. So, you know, we said, okay, well, how do we get the power? And so we went to some of our mentors, and we said, you know, all right, what do we do? And we sort of adopted, she recommended adopting sort of these governing principles. First of all, understand that power concedes nothing. So, you know, when we meet with the union people and they say, oh yeah, great, that's really important, but like we can't do it. They have the power and they're not going to concede to our demands unless we actually build counterpower so that we can win. The second part of this principle that was really important is to be programmatic. So put forward a comprehensive platform of worker needs that includes safety, and that would form the basis for making a coalition with other people, which we then, you know, move forward to find groups organizing around specific issues that intersected and overlapped with our own demands. And then to do what Adam said, to educate all of our fellow workers about the pandemic and the kind of ongoing dangers of it, which, as everyone here knows, have been sort of so systematically underplayed by the Biden administration and the CDC. And then to use all channels. So as much as possible, Twitter, in person, on the picket line, on the virtual picket line, in chat groups, et cetera, et cetera. Next slide, please. So as you see here, here's an excerpt from our open letter. We first wrote an open letter as a Google Doc, and then we reached out to Pest Magazine, who published it. It's up here as University of California Academic Workers Strike Organizers Demand Disability Rights. That got us a fair amount of visibility. We then had some journalists who, I should say that it's really important to note here that we didn't build this infrastructure on our own. There, as Adam mentioned, was already a very effective and active disability justice group, primarily at Davis, and another affiliated, a sort of an official union committee, and then a sort of outside committee called UC Access Now, who has been advocating for months and years around disability justice at the UCs. In particular, UC Access Now was instrumental in putting forth an article for our contract and negotiation called Access Needs. And one of their central demands, so basically access needs as opposed to reasonable accommodations, which implies that, you know, the university is doing people a favor. Access needs is a sort of proactive way of saying, no, these are actually the working conditions that we need to be able to have equitable access to doing our jobs and to our educations. And they put forth this really amazing article, a central demand of which was to remove the requirement for medical documentation. Now, the ADA does not require medical documentations, but many workplaces like universities require workers to go through this burdensome process to provide medical documentation to meet their access needs. So they had done this wonderful article that was actually sort of gutted by the UAW affiliated bargain teaming. So they were sort of members in our strike, members of the bargaining team that were sort of more aligned with the UAW and members that were more progressive. And so that article had been sort of progressively gutted, but in the process, they built this very strong base of disabled and other workers who supported disability justice. And we definitely built on that network. And so one thing that we did as soon as we sort of, we had our Google Doc letter, we collected signatures on it. Then when the letter was in PEST, we sort of got many more signatures, is that we started to go into, we sort of would, first of all, invite people from that. It's kind of classic organizing, right? We'd invite people from that list, people who signed the letter, we'd invite them to come meet with us with the bargaining team. We would show up at bargaining sessions, at caucus, at union meetings, all of which were held online during the strike. And we would put the letter in the chat. We would text about our access needs. We would text about the need for COVID safety. We would text about sort of message in the chat about masking. And sort of through this process and through these existing networks, we started to build a kind of wider, like a wider net of people who had felt really alone. Because it's interesting, Adam began the story with talking about a sort of grievances that were filed around the reopening, unsafe reopening at Davis. But the same thing actually I learned happened at Berkeley and was again in a similar way shut down by the union, and the people who had kind of spearheaded that were made to feel isolated and alone and like they didn't know what they were talking about. So a lot of this process was really, building back that power and really telling each other that we're not alone, that it's completely reasonable and actually just to want protections for each other, and that we can fight for this collectively. Next slide, please.
So, like Mary was saying earlier, we were originally told that we cannot add a new article into these contract negotiations. And eventually, when we learned that that was not true, we reached out to bargaining team members and attempted to work with them to write up an entirely new article that included these COVID safety provisions and also kind of more general pandemic and public health preparedness provisions. And we were a bit stonewalled by a lot of union staff, and we were told a lot of things weren't legally viable, that our outside legal advisors and mentors confirmed that that was actually not the case. So we decided to go outside of official union channels, and we wrote our own article ourselves and worked with lawyers to figure out what is possible, what can we demand. And so here's an outline of that really ambitious article that we put together that was focused on having provisions specifically for evidence-based public health guidance. So not just politically based public health guidance like we're seeing right now. Having online work access without needing medical documentation. As Mary said, it's a really burdensome process. It takes months. Maintaining stocks of high quality masks to distribute, making ventilation upgrades to meet standards, continued access to free PCR testing, lifting the ban on having an instructor or someone require masks in a class or lab space, require routine surveillance testing so we can actually see transmission on our campus and adjust things accordingly, having CO2 monitors to check ventilation and airflow. And also most importantly, or not most importantly, but very importantly, having workers included and having equal power when it comes to determining campus-wide policies, because a lot of these are just kind of unilaterally decided by chancellors and their private advisory committee, and then they're just imposed on the campus. No one else really gets to say. It's very undemocratic. So this was our original article. Unfortunately, it didn't make it into the final contracts that were ratified, but we were able to put this together with just ourselves. We did not need to rely on the union channels and go through their bureaucracy. And we've already had multiple other groups reach out to us and build on our original article for their own contracts to figure out what they are able to secure access to. Next slide, please. So as I was saying, we're a bit stonewalled by union staff. And so we stopped going through union channels and went to where the power really was, which is the rank and file. And so the ways we took action around COVID safety and disability justice during the strike, like Mary was saying, we showed up and we spoke out. We went to caucus meetings. We went to town halls. We held teach-ins. People were speaking over the loudspeakers at picket lines in regards to what's going on with COVID, how people can protect themselves, how the union should be stepping up to help protect these workers. And we made it personal. We shared our own stories about what life has been like for us as disabled workers during COVID, what steps we need to take every single day just to ensure we don't get a virus that could further disable or kill us. And we, like Mary was saying, we repeated ourselves over and over again. We were incredibly persistent with how we got this message out. And over time, we identified more and more allies. We brought them into our network. We were able to spread the word far and wide. And especially because a big topic for this strike was disability justice and getting disabled workers their access needs met. So we would call union leaders out to their face and tell them to put their mask where their mouth was if they were actually concerned about disability justice. Put it into action, take the steps to actually protect us. And over time, we saw this working. At UC Santa Barbara, on their picket line, we were able to get strike captains to start handing out masks whenever someone signed in for a picket shift. We were able to get masks required at certain meetings. We were able to get meetings hybrid. And so over time, we gradually saw these very clear gains that we were making because of our persistent effort and because we were building this coalition over time. And we were distributing information the whole time too. Like it says here, we had an FAQ about this new article that we wrote and about the original access needs article so that people were getting the facts directly and not getting it through a kind of bureaucratic machine that was gonna gloss over the things that they conceded on or say things that we could and couldn't do. Next slide, please.
So as Adam says, next slide? No, sorry. Go ahead, Adam.
No, this is you, you're up.
Okay. I was on the wrong slide. Sorry, guys. So right, as Adam says, by this point, we had a very active signal chat with about 80 people from across the state. When we say we were able to, we mean there were people who had been trying to do all of this work alone and who had been doing COVID and other and disability justice advocacy in kind of smaller groups, or actually almost completely alone, who had felt completely, again, isolated. We looped in and we were kind of sharing resources and telling each other what we were doing. And of course, at the same time, there were lots of other groups organizing around different demands. So for example, if you're familiar with the strike, you know that one of the main demands that we had was a cost of living adjustment because of the incredibly high cost of living in the kind of cities that these UC campuses are located, called COLA. And we had a 54K wage floor demand. But there were also kind of small, I wouldn't say smaller, actually, there were also additional articles organized by specific groups, like, for example, parent workers had put together, had been advocating for, I'm also a parent, as you can probably hear, had been advocating for childcare subsidies and dependent coverage. International workers were advocating for a fee remission so that they are not charged additional fees if they don't graduate within a sort of certain set, completely absurd small number of years. There was also a community safety article that was written primarily with regards to defunding the university police and to kind of keeping students who are typically targeted, Black, Indigenous, disabled, and other students who are targeted by the police, by police violence, safer on campus. And these different groups were all kind of coordinating across different chats. And we would sort of, yet again, we were all very active in those. We would show up again at meetings and advocate for those demands also, because in fact, those demands are our demands, much as we started to learn that our demands are also other people's demands. For example, online access is something that student parents really need for meetings that happen, for example, at 5, 6 p.m. when we're at home and we have dinner time and we'd like to also attend union meetings, for example. Being able to have a Zoom, a proactively online access to those union events is actually incredibly important. And so we all started to understand that our needs and our demands are intersectional. again, we created press releases. We sort of did our own work. We created press releases, and as these other groups were also creating stuff, they started incorporating our demands into theirs. So they would reach out to us and they'd say, we made a slide for Instagram about access needs. Like, could you please fact check it? And then people from our group would fact check their slides, and then they would post it. We organized a coalitional town hall where some 500 people attended. We co-organized that with one of the members of the kind of progressive members of the bargaining team, where each different person or kind of group who had worked on one of those specific articles was able to testify about why those articles were so important to them and to sort of other workers like them, so that we could understand yet again how much our demands overlapped. We recruited other comrades and allies to join our efforts. And then when the bargaining team sort of really quickly pushed through a very bad contract, we all kind of got on board with fighting for a no vote and yet again, creating infographics about access needs and the other kinds of demands that we all shared. Next slide, please. So the kind of really beautiful thing I have to say that happened, one day sort of towards the end of the strike, I received this email in my inbox on disability justice, the UAW statewide communications reference reasonable accommodations, and essentially saying, that they dropped the access. So sorry to say, to back up a bit, in this bad contract, they end up dropping the demand for access needs without medical documentation, despite the fact that hundreds of workers through our networks and otherwise showed up at meetings and testified these, incredibly personal and detailed and difficult stories about their inability to be able to do their work equitably because the university was creating all of these loopholes for people to jump through, right? And still, access needs was dropped from our contract. And it became like a really central rallying point to all of the groups that were fighting the tentative agreement and fighting for a better contract. And so one day, like I said, I wake up, I get this email that says, abandoning the coalition of disabled student workers who had organized to fight for an equitable, fair, and safe workplaces across the UC. And this email is literally quoting things that Adam and Megan Lynch and Heather Ringo and Raj and all people who were organizing with us had written, and linking in fact to the People's CDC. And we didn't know who wrote this email. So our demands took on a life of their own. They started becoming perpetuated within these spaces. And we started seeing again, meetings, announcements for meetings where masks were required and handed out at the door, only 4 or 5 weeks into the strike, whereas at the very beginning of the strike, nobody was talking about masks. So our movement really quickly showed that people do in fact still care about keeping each other safe. They do still care about COVID. We saw this play out in action. People care about keeping each other safe, but there's been so much misinformation, and I could sort of go into an analysis of it, which I won't here. But really, when we personalize it and we ask people to take care of each other and to take care of us, they do. Next slide.
So then, in addition to rank and file sending out these communications quoting us, we finally started to get actual official union communications requiring masks at certain meetings and taking up these precautions, again, to show that when we are persistent and when we fight this uphill battle, we can win and we can make progress. Next slide, please. So, and this was really interesting because this study that is screenshot here came out of the CDC, and it basically shows that when people think COVID transmission is high, they will willingly take on precautions. They don't need a mandate or anything like that. The issue is that people never think COVID transmission is high anymore because we're getting all this misinformation and misconstrued from whether it be corporate media, whether it be the federal government, whether it be the CDC. And so we saw this play out in real time because we were able to share the wonderful resources from the People's CDC, like the weekly weather report that shows very clearly, hey, here's the transmission map. Here's what's actually happening. This percentage of the population is in like a substantial or high transmission zone. And so we show this to people and then they're like, oh yeah, I should be wearing a mask at the picket line. Or maybe I shouldn't go to that in-person meeting and just attend via Zoom. And maybe I should be talking to my friends about wearing a mask and doing a test before we go to the picket line. So we saw this play out in real time right before our eyes. And it was incredible. And yeah, like Mary was saying, we constantly hear, oh, everyone's over COVID. We need to move on. It's in the rear view mirror. This is a wedge issue. No one cares about it anymore. That is simply not true. People care when they think they need to. The issue is they just don't think they need to anymore. But when you educate people and show them the reality of what is happening and how it affects people and how it could affect themselves, they will care. Next slide, please, and Mary will take us home.
So as Adam says, when people care, they will do the right thing. And so therefore we are not done yet at the UCs or anywhere. California has adopted a new OSHA, a non-emergency COVID prevention regulation. It's not perfect, but it does have masking provisions, contact tracing, provisions for remote work and ventilation upgrades across public buildings. So basically, this is incredibly important. Everyone should go take a look at it. We will put a link to some of the documentation on it in the chat, but we need to fight essentially for its enforcement, which happens through pushing with legislators, through essentially working through unions, through working outside unions, which is essentially the place that we are right now. And to basically get that regulation into action and to put into practice, and to having a federal regulation that is similar for airborne virus workplace safety that is applicable across the country. So essentially what we're working on now is leaning into collective action to move forward with what we want, to get our demands from outside the union. And so some of our, again, take home points before as we kind of close out here, the things that we learned to sort of circle back and to evoke here, Mindy Fulilove, you have to build coalition. You absolutely have to understand that power concedes nothing. So we have to build coalition. We have to find other people who similarly kind of agree with us. Something else that's incredibly important that I would like to re-emphasize here is that the ban on instructors asking for masking in instructional spaces is a violation of the ADA. It is therefore illegal. And so what we're working on right now within the UC is putting that into practice, is just not accepting it, is saying, okay, let's create a pamphlet for people to be able to understand what their rights are and to unilaterally, and in fact, the union suggested that we do this a few months ago, unilaterally require masks in our classes anyways, and wait for retaliation, because the universities are not going to retaliate because they know that it's illegal, or they will find out soon. Unilaterally move things online. And the kind of other final kind of take home point that I really want to drive home here is that part of how we were able to do this is that we really supported each other. We created spaces for people to express our difficulties to each other. We had a chat, we had community standards within our group chat. So we had sort of rules or agreements for how we wanted to interact with one another. But it was incredibly important, and has been and continues to be incredibly important, to have this mutual support, mutual aid space while we are coordinating around our actions and building trust together. And finally, encourage and create empowering frameworks around collective action. When people feel that we are alone, when people feel shamed that we are wearing masks or asking for protections, we feel disempowered. But in fact, it's a wonderful and beautiful and incredibly important thing that we are doing by advocating for safety for ourselves and for each other. And I hope that that is what people will take home, because in fact, when we work together, we find that collective intelligence and collective action is far greater than anything that we can do alone. Thank you everyone so much. And I'm going to turn it over to Danny from the Weather Report team.
Hi, good evening. My name is Danny. I'm a biostatistician, whoever can hear and see me. I began working with the People's CDC several months ago. And I just briefly wanted to go over the weather report that we publish weekly, what it is, how we create it, and other projects that our weather report team is involved in. Next slide, please. So each week, our team creates the weather report, which, if you're unfamiliar, is an overview of COVID transmission, variant trends, wastewater monitoring, hospitalizations, deaths in the past week. The purpose is to provide the most important information on ongoing trends in an accessible format. We collect our data primarily through CDC COVID data tracker, and while the data is not perfect and often underreports for a multitude of reasons, we are able to offer analysis and commentary on trends week to week. Next slide, please. So along with weekly updates on COVID transmission, the weather report also highlights recent publications from peer-reviewed journals, critical analysis on state, local, and federal policy, commentary on relevant news, and we also highlight advocacy and ongoing struggles related to the COVID pandemic. These additional updates are gathered by all members, usually at the discretion of the writers on a given week and fact checkers. The weather report group will often share new research throughout the week that we would like to highlight, and we also engage in discussions surrounding how a given policy may or may not impact the ongoing efforts to protect and promote public health. We publish our weather report on the People's CDC website, as well as nearly all social media. The weather report team also creates ad hoc reports, guides, toolkits, one-pagers, FAQs, anything really. These projects are typically born out of sometimes mixed messaging or confusion on what the best practices are, difficulty finding, critical information. I personally worked on the what to do if you have COVID document, which was started when we were discussing isolation, and for several different things. Like, we may know what we're being told is how long should we isolate, but what are the best guidelines related to research? How long are you potentially infectious, or what does recovery look like for a COVID infection? This required rigorous literature reviews on most recent publications. Our supplementary projects are also written to provide clear and concise guidance and recommendations at a time where it's often difficult to find. Next slide, please. The weather report team meets bi-weekly on Wednesdays usually to discuss who is responsible for the tasks surrounding publication of the weather report for the following 2 weeks. Once the rules have been established, the writers can begin to gather data from CDC COVID tracker, typically on Thursday or Friday prior to publication. Around this time, the People's CDC Quant team will send us an updated transmission map as well. Saturday and Sunday, the weather report is fact-checked and proofread by at least 2 individuals. And if something's flagged, maybe the larger weather report group will be asked to weigh in on various interpretations. Once everything's checked once and double-checked, the weather report is published on the People's CDC website. Our graphics team within the weather report will then get the weather report ready for publication on all social media platforms. The weather report team utilizes WhatsApp chats to coordinate throughout the week with each other, as well as discuss policy, research, or anything else related to this relevant information we want to publish within the weather report. Next slide, please. So our weekly roles typically include 1 or 2 authors who will interpret data we present in a way that is accessible to the general public, fact checkers who can evaluate scientific evidence as well as critically analyze policy, proofreaders, alt text writers for helping create more accessible reports, graphic designers, videographers, artists for publication of our work. Our team members come from a variety of backgrounds, and there's always a lot to do with the weather report team. So if you're interested in joining us, please sign up at peoplecdc.org. Someone should reach out to you. I'm going to pass off now to Sam with the community team. Thanks.
Thank you. I'm Sam Friedman. I've worked on AIDS and related issues for many years. Next slide. The community team is trying to produce and promote COVID safety. Now, we are not a huge group. We're going to be assisting both worker and community groups, and have been, with prevention and treatment organizations, and also with advice on how to organize through encouraging activism and stuff like that. We've done some strike support where we've been able to. I put as an answer to a question in the question and answer thing that if you have questions, for example, what resources are available to help you in a given area, or if you need a labor lawyer, or if you need help as a rank and filer or as a rank and file group dealing with a union that's not responsive, get in touch with us. We're in touch with people like Labor Notes and other groups that have been helping people like that for a while. And, we're going to be working with Adam and Mary very much to get their ideas out to other people. We'll be writing documents on it, which we will get out. But one of the things you may or may not have noticed in what they presented, they had a lot of time and energy to do all that. Not just them, but the groups who were working with them. And when you're in a contract negotiation or a strike, you have that kind of time to be able to do that kind of collective action. So we will be working with people, for example, around the UPS negotiations and potential strike to try to do similar kinds of activities. And we'll help you. Hopefully some of you will get in touch in the sign up stuff to help us, to sign up for the community team to do that. Next slide. We've already produced several documents. One of them was recent on supporting the railroad workers fighting for humane conditions and paid sick leave. Another was, we noticed that people in the community were getting very confused about boosters and variants and all that. So we wrote a very short document to help explain that. And it's on our website and available. And we also wrote a longer document about how do you actually fight for worker safety during COVID, which takes up some of the same kinds of issues that Adam and Mary were talking about, but puts it in the context of who can you reach out to, what resources are out on the web or elsewhere. So that's another place you can go for help. And now I guess it's next slide. Oh, okay, we have another slide I didn't know was there. Some of the projects we're working on is building an online repository of materials regarding COVID workplace safety. And we're working with Kosh and Labor Notes to do that. The second one is what I was talking about in part, how rank and file workers can contribute COVID and other safety content to contract negotiations and campaigns and actually win them. And we're going to write up some case studies to make that more concrete. And we're also going to work on a document, go back a second, on when federal money goes away. It's federal support for various things like Paxlovid or tested or vaccination go away, and your area doesn't have them in some other way. We're going to help provide local resources for that or help you locate resources and develop materials on how worker and community groups can pressure local, state, and federal governments to fund what is needed. And we're going to be doing a lot of outreach to the extent we have people working with us. Next slide. And now off to Lara.
Hi, everyone. Great to see you. And thanks so much for attending and joining us and being with us tonight. I'm going to be presenting the external review. And the external review, as you may have been following the news back in spring and summer of last year, is a bit of a response to the CDC's own internal review that they did conduct. Next slide, please. So at this point, we've had almost 1.1 million COVID deaths in the US and millions of long COVID cases. And unbelievably, many politicians and even some medical professionals are suggesting that the pandemic is over. But just looking at these numbers, COVID has been in the top 10 of the top 10 causes of death for adults, and actually in the top 10 cause of deaths for children for the last 3 years. And so when the CDC announced that they were doing their own review, we in the People CDC decided that it was time to launch our own. Next slide. So via a modified Delphi process through iterative rounds of conversation with a bunch of public health experts and affected community members, we developed a set of 8 areas of pandemic management that we identified as priorities. They include disease control, ethics, equity and justice, scientific integrity, communications, public health infrastructure, inclusion, and addressing root causes. Next slide, please. And ultimately, we ended up creating a survey focused upon those 8 areas, and we disseminated that survey primarily via email and via our public health networks, and also by direct outreach to community organizations and leaders of affected communities that have been primarily impacted by the COVID pandemic, and also in collaboration with Marked by COVID that put it out on social media. We eventually surveyed nearly 500 health workers, community leaders, public health researchers, and practitioners, as well as people who've been affected by COVID. We reviewed over 200 research articles, white papers, and pandemic policy proposals and newspaper articles. This is a tremendous body of work. The resulting report incorporates quotes like the one on the left aspect of this slide, which says, the CDC has undermined its historical reputation for public health. It should adopt a proactive science and compassion-based pandemic control and prevention strategy, which really sums up a lot of the findings within this report. And that quote is from Yanir Bar-Am of New England Complex Systems Institute. And then we eventually incorporated some quotes, many quotes, and also the report was then vetted and reviewed by 25 of the survey respondents and other People's CDC members. So a lot of eyes have seen and approved this report. Next slide. And ultimately, you know, as we think back and reflect on what is happening, our administration is, you know, sometimes sending these messages of hope or, you know, don't worry. But if we look at the cold, hard numbers, we can see that there's plenty of reason to continue to be concerned. And we should be concerned in 2 ways. First of all, you know, this idea that, oh, well, COVID's here, there's nothing we can do about it, is obviously and blatantly wrong. Just as you look at the numbers, life expectancy in the US has drastically dropped, and in particular in comparison to peer nations, some of whom have already started to stabilize and turn around some of that decrease in life expectancy. This image on the left here, you can see US in comparison to peer nations. The US is the curve, the lowest curve in red as compared to other peer nations that are depicted in black. And then also that decline in life expectancy has been multiplied many times over. And so in particular, groups like Hispanic and Latinx, Black and American Indian and Alaskan Native patients have actually experienced even greater declines in life expectancy. Next slide, please. And so ultimately, as the CDC COVID response coordinator, Ashish Jha commented most recently, actually last week, regarding the serious risk of continuing to allow COVID to spread unchecked. Our message to the administration is, yes, we agree with you. COVID is a serious threat, but sending the message that COVID is a serious threat without any remedy is just simply false. It puts people into despair and makes them shrug their shoulders. And as I often like to say, the National Weather Service doesn't say a hurricane is coming, you know, we predict that this many people will die, you do you. Community is our best defense. There is a response to this, and we have some more answers for you, hopefully in the upcoming month or 2. Stay tuned for the release of the external review, and we'll be looking forward to sharing it, hopefully via another webinar. Thanks so much, and I will turn it over to Karen in the art team. Thank you.
Hi, thanks so much. I'm Karen McPhail-Bell, calling in from Maloney Country on the San Francisco Bay Area. I'm an artist and a health and community researcher. Next slide, please. I'm super happy to be able to share some of what the PCDC artists have been up to since we got going in 2022. So what are we about? PCDC artists seek to build collective power and equity in our work for health for all. And we do this by nurturing human expression through art and arts-based approaches. So since our small working group got started, we have hosted an open mic and generative workshop and had a number of informal virtual creative gatherings. So today we'll give you a sneak peek into some of the creative work that's coming out of our group. Next slide, please. So I'd like to first pose a question. What does it mean or look like to make pandemic-related art? So art related to these times may or may not be obviously about COVID, be it to the viewer or even to the creator themselves. So some art is obviously about the pandemic, as you can see in the image on the left here by Hope Brassfield. Hope started making buttons after her partner gave her a button maker as a fun thing to do. And she seeks to bring laughter through her buttons. And they're usually about COVID themes, such as this one, which was, what can I wear to the grocery store that will stop people asking me, why am I wearing a mask? Or asking me to see my smile or laughing at me. So a button could be seen as just a silly thing, but let's remember that play and joy are both critical to public health as well. Some art is not so obviously about the pandemic, but addresses issues that are key to the COVID experience. So in the middle here is my latest painting called Moved On. And this is an ode to the residents and visitors of a historical landmark where I live in Redwood City called Hotel Sequoia. This was built in 1912 as the Silicon Valley's most excellent hotel. In recent decades, it has been home to SRO residents who in the past months were moved on, and the hotel is now empty, awaiting the renovation planned for by its owners. And evictions are a key part of the COVID experience for many of us, as is homelessness and cruelty to the unhoused. And perhaps all art made during the pandemic is actually pandemic art, given that art is an artifact of its time and socio-cultural and political context. So as an example on the right is an image by Rachel Drymiller. She shared this during our Pandemic Pleasures open mic night as an example of simple pleasures that they're getting into during the pandemic, in this case, getting back into embroidery. We also have two poems to share with you. The first one is by Ryan Pettaway, and it's called Black and Mild, a tutorial after the CDC. And you can hear Ryan reading this on the Health Promotion Practice Journal's podcast. And the second poem we have today is by Sam Friedman called Lot's Wife Adrift in the Coronaverse. And I'll hand over to Sam now. Thanks very much.
Lot's wife adrift in the coronaverse, agog at the saltwater tears of politicians and businessmen who force hungry employees to work cheek by jowl in air swarming with viruses, and beset by media blaring always, accentuate the positive, look ahead, never ever look back lest you become a pointy egghead. She watched the powerful abet the virus to be fruitful and multiply, even as the virus mutated beyond all control. Until she herself looked back to learn what might have been, and seeing behind what lies ahead, dissolved herself in tears. Next slide. And now I hand over to the Quant group where an anonymous X will be reporting.
Hello, I am X. Next slide, please. Thank you, Sam. So along with the exposure map Rob explained in his COVID This Week presentation, the Quant team is involved in adapting federal and other data for better public presentation. With COVID caseload data deteriorating as states begin to reduce reporting and with home testing becoming more popular, we're aiming to map excess deaths per county. Here, our team, led by Les Schaefer, is in the midst of experimenting with different ways of presenting hospitalization data by facility rather than by county as CDC does. Here are the fraction of hospital beds filled by COVID patients across the 4,000 plus hospitals reporting as of December 30th. We see in the redder dots of the Seattle and the Bay Area particularly harder hit, but also in the Twin Cities, the Houston area, Southern Wisconsin, Ohio, Atlanta, Charlotte, and up the northeast seaboard into Massachusetts. Next slide, please. Besides mapping excess deaths, the Quant team has worked on building Breathe Safe, an app to help people find safer venues. It quantifies risk of transmitting COVID. COVID, as we know, is transmitted by tiny aerosols that can linger in the air for hours. It uses behavioral information along with environmental information to assess risk. Besides helping people find safer venues, another goal is to arm indoor air quality advocates with data and analytics so they can ask for structural changes. So one may wonder, what is the ventilation rate, for example? That is good to know, so you can ask for better. Next slide, please. So here on the left side, we have a map with different icons signifying different types of venues. Each icon is color-coded by risk, where red is very risky, while green is least risky. So for example, on the bottom, we see like two restaurants. One is yellow, one is red. And then on the right side, we have a list of room information of these venues, address along with the risk score from A to F. You can search for different venues using the filter. It says search for events in the top. You can use the geolocation button to sort the venues by distance to the user. You can show what would happen to an individual's risk when doing one-way masking versus when universal masking is taking place with surgical masks, N95s, or elastomeric masks. For example, everything goes green on the map when universal masking with N95s are taking place. If we had mask requirements and everyone adhered to said mask requirements, places would be much safer for immunocompromised and disabled people. Next slide, please. So here's an example of how to add information. And the left side asks for general information about the room. To measure ventilation in the middle, one could use a CO2 monitor. So CO2 ambient is what's the CO2 reading outside. And then one can add CO2 readings indoors in that space that you're trying to measure. One can also add information about how many people are in there, what people are doing, as that could affect risk. Speaking increases the amount of aerosols produced relative to just breathing. And likewise for CO2 generation of people, if people are sitting, they're generating less CO2 than, say, if they're exercising. So knowing that information helps us calculate ventilation rate. Next slide, please. So what does that give us? So it gives us an analysis page. On the left side, we focus on the interventions where we have masking interventions, no mask in this case. And then, for example, for portable air cleaners, what happens if we add a portable air cleaner, for example, a Corsi Rosenthal box? And here in the duration, what if you stayed there for 8 hours? What is your risk? And so here in the middle, we show what the average new infections are. So this is saying in 8 hours, there would be about 1.6 average new infection. So about 2 people on average would be infected. And one could experiment on the left side to see what types of interventions would make it so that the average new infections is under 1. And if we're able to do that in all the places, then we can stop the transmission of COVID. And then, more statistics on the right side, like what the CO2 concentration over time would be if you had, this type of ventilation rate, for example, 14 cubic feet per minute, et cetera, et cetera. So next slide. So goals in the future for Breathe Safe. So one thing is we want to specify whether or not a venue meets IAQ standards. And we're interested in lending and distributing CO2 monitors to increase data so that this becomes more usable to a bunch of people. So if you're interested in contributing data to Breathe Safe, please email at info@breathesafe.xyz. And finally, if you have some mathematical statistical modeling skills, if you like to visualize data, you have some software engineering or data cleaning skills, or you like to think about numbers, please join the Quant team. And with that, I will give us to Chloe and Danny to talk about the pressure group.
Okay, hi, I'm Chloe, and I'm going to talk about the pressure group's mission. Our group promotes vital public health solutions and policies through effective messaging and information tools such as letter templates for people to use for their own advocacy. You're invited to join us in advocacy action, developing pressure campaigns to petition, write, and call public officials to protect everybody. Public health is not about focus protection or othering and cannot rely on individualist choices nor market solutions. Public health entails solidarity with all of society. We are all stakeholders. The pandemic's risks and consequences are unpredictable and they affect us all. This requires pressure for action. Next slide, please. This is an example of the Action Network form, which is a tool we are using for some of our letter campaigns and petitions. This petition is to the White House and the Biden administration and the officials involved with the response to put pressure for a requirement for masking in all healthcare settings. We have almost 4,000 signatures now. Next slide, and Danny is next.
Hi, so primary prevention is crucial. Our main aim is to highlight the urgency of multi-layered action to prevent transmission. The US has failed to truly address primary prevention and instead relies largely on medical interventions, or as Rob called it, pharmaceutical interventions. Officials, media, the public talk as if death is the only outcome to fear from COVID, largely ignoring the often devastating and disabling impact of long COVID. So our team's focus currently is prevention of long COVID as a key reason to prevent COVID. The only sure way to avoid long COVID is to prevent COVID. Next slide. Comprehensive prevention requires wide-ranging policies, a lot of what you've heard already. Examples are remote work and school options, paid sick leave and other supports for isolation and recovery, reduce crowding in congregate living, shelters, jails, assisted living, regulations and public funds to improve air filtration and ventilation in both publicly owned and private buildings, widespread free testing and masks, mask requirements, multilingual public education on infections, prevention, and long COVID. Next slide. Other works in progress. We've drafted a template document on myriad ways long COVID impacts individuals and society and broad prevention agenda to press state and local health departments and elected officials for action. To reach the general public, we're also seeking to publish an op-ed. We'll prepare versions that focus on specific populations such as young families, at the suggestion of those who have been publicizing the global consensus statement on COVID, recently published in Nature. We also aim to highlight the moral imperative, the nation's obligations not to neglect the highest risk, not to leave anyone unprotected. Next slide. Where do you think we should be applying pressure? Join our team so that we can act on it. And thank you.
Cool. Thank you so much, Danny and Chloe, for that, and all the panelists so far. So if you've watched the webinar to this point, you might be thinking, how can I get involved with the People's CDC? So first things first, follow us on social medias. Twitter, Instagram, YouTube. I know Mastodon, we're working on getting that up and running. Give us a follow, like, share our information. As what you heard today, a lot can be done with just sharing information. And when people know and have the facts, they're more likely to take precautions. So take what we're putting out and share it with your friends, share it with your local networks and the people around you, because that's how you build community. Also follow us on Substack. Substack, we release the weather report every week straight to your email. Also, any of the pressure group petitions that come out or anything from the community group, you can find those all straight to your email. Another way, you can scan the QR code that's on the screen currently, and that'll put you to a form you can fill out. We've had a lot of volunteers sign up recently, so we're a little backlogged there, but we're working through them, and we would love to get more people involved. Like you heard Mary and Adam and everyone else speak about, this is about community building, and we are building this community, and we would love your help. And finally, I can't believe I didn't put it on the screen, but go to our website, peoplecdc.org. You will find all the resources that you will need. Everything will be put up there. You can go there for the most recent information. And like I said, share that far and wide with as many people as you can, because the more people that know about this, the more people that are still taking the pandemic seriously, the more people we can keep safe and the more communities that we can keep safe. And yeah, with that, I'll pass it back to facilitator Molly. I think we have about 10 minutes so we can answer some of the questions we weren't able to get to in the chat.
Thank you, Firas. And thank you so much to all of the presenters this evening. As someone who's a member of the People's CDC, I'm aware of the work that's going on, but seeing the breadth of what's been accomplished in this year has really been extraordinary for me this evening. So thank you all for sharing that with us. And it's just such a profound reminder of that people can come together who have never worked together before and learn how to work together and start to be effective. So thank you all for sharing that. There's a lot of questions that have come up in the chat, but I have observed that our team has been steadily answering them, especially some of the more specific questions. So please keep putting your questions in the chat. If you feel you have one in general or you want to direct someone, we have a few minutes. But before we got to that, I wanted to ask a question of the panelists and our People's CDC members and friends, and see who wanted to answer this, but I'm going to start with Lara, if you don't mind being put on the spot. But the question is just, we've had this People's CDC for a year. We're a year in, it's basically our 1-year birthday. And if you would be willing to share what's a key thing that you've learned from this experience and what you see for the year ahead. I don't know, I can't see you. I can only see myself on the spotlight and the slide. So I'm not sure if also if anyone else is excited to answer that question. Please feel free to come off of mute, any of the panelists. Well, I will say that a lot of people don't have their camera on who are the panelists, but I do see you, Karen. So Karen, would you be willing to answer my first question, which is just, what's a key thing that you've learned from this experience of being part of the People's CDC?
Thanks so much for the question. And I love the question. And for me, one of the things that is a key, I guess it's not just a learning, but it's reiterating something that I know is really important for public health. And public health is a collective act. And this is about health for all. And that means that there's a space for all to be involved. And it's phenomenal to see how the PCDC has self-organized in this way. And like ever since the Alma Ata Declaration in the 70s has come about, we've known that a people's health movement is critical for health for all. And it still is so, so important now. So, you know, for folks who are thinking of getting involved, I just really hope that you do, no matter how big or small it is. Like, this is really about a people's CDC and a people's health movement.
you so much, Karen. And Mary, I see that you have a hand up.
Yes, I want to add a couple of things when my children get kids away. It's incredibly important. Part of what allowed us to do the organizing that we did at the UC was that we were not alone. And I guess that there's all, I mean, the UC is a huge campus, it's a huge workforce, but finding one other person just was essential to getting started and organizing. I'm sure that in all of the spaces that everyone is in your workplaces, in your places of worship, in your schools, there's at least one other person that you can talk to and say, we believe that keeping each other safe is essential, and how do we get started? And you just take small steps. It's essential, though, that we win back these public spaces. I know a lot of the COVID advocacy has been happening on Twitter, online, and while it's certainly essential to put information out there, that is one of the central things that the People's CDC does, is that we create scientifically, sort of sound, fact-check, accessible information about the pandemic. But ultimately, we have to win ground in the real world. And there are ways to do that safely. There are ways to do that without even necessarily going to places in person if you're high risk, or, I mean, again, all of us are at risk for long COVID. But we have to follow people like Mask Mandates New York and Mask Mandates US. They are laying out a really interesting and effective sort of model for attending Metropolitan Transit Authority meetings, testifying online, testifying virtually. But we have to organize, we have to win back spaces because we can and we will.
Thank you, Mary. Sam?
Yeah. As we build power by reaching out to one other person and starting, as Mary said, people often feel that's too difficult. Let me tell you something. It's fun. You make lots of new friends. When I look at the pictures of the other people in this group, I see a group not just of colleagues and collaborators, but friends. I've only, since this thing began, I only actually physically met with one of the people in this group who came and drove down before she moved to upstate New York to meet with me and my wife. But, I'm friends with everybody here. And you too can do that and have a lot of fun doing it.
Thanks, Sam. Rob?
Yeah, I endorse what Mary and Sam have said 1,000%. I think it's both an important political action and also a personal action to get involved with things and not allow yourself to be cut off from the world. Look, People CDC, we're not the CDC. We're not a $12 billion federal agency. We don't have thousands of employees. We are community members from across the country. Some of us are professionally trained, some aren't. But the point is that we respect expertise from a variety of places, because it's that combination of expertise that's going to solve this. So our job is to put pressure on the CDC to do the right thing. So we have our pressure groups, we have our op-eds, we have our external reports, but we're also trying to display an example about how the CDC should be operating, right? So we have our weather report every week. We have our COVID this week. We're trying to show that you need to communicate with the American people about where we are with the outbreak. And that's not happening at all on a regular basis. They're all trying to pretend this thing is over. They are engaged in a magical thinking to pretend that COVID is just going to go away by itself. This is why every week I talk about all the new variants that are emerging, the ways in which they evolve out from underneath the so-called tools that are supposed to end the pandemic. So this is, unfortunately, we see ourselves continuing in operation at least another year, in part because of the other denialism that is in play, both at the federal level and at the state level and in other countries. So we very much appreciate your showing up today. We would very much appreciate your volunteering to help out with us. There's a lot of work to be done. Be patient with us if we can't get to you right away, but we very much operate on people power, and we need the people to help us. So thank you so much for showing up today. We deeply appreciate your support, and hopefully we'll talk to you soon.
Danny.
If there's any questions, I want to defer to let other people ask a question, but I can answer too still.
Yeah, that would be wonderful, Danny. We would
Okay.
love to hear what's a key thing you've learned from this year.
So I mean, I think what's to learn is really, it's not so much what's to learn, it's what we've gained. The fact that, you know, that the policies have done so much to isolate us and to, you know, gaslight us and make us think that somehow, you know, everything's over, everything's fine. And the peer pressure for people to just go on about things the way they are, you know, like nothing, oh, go back to the way things were, which has been really dangerous. It's creating more opportunity for more variants to keep shaping and figuring out other ways to get to us. And you know, just being able to have a group that you actually, you can feel like, okay, I'm not crazy. And to, you know, continually look at how to get more information so that you can, you know, be on top of it and hopefully try to move your public health departments and to act responsibly. That's really what I've experienced. It's not what I've learned.
Thank you so much, Danny. So in closing, I want to say thank you so much to all of our panelists. Thank you so much to all of you for joining us this evening for this webinar, Communities Are Our Best Defense. We're a year in, I think, as a People CDC and as a group of people learning how to work together. We've learned a lot this past year about how to research and put out information and make it accessible and share it through various channels. And we've talked a lot about how this coming year is really about how we're making sure that we're organizing with this information and really looking to take Mary and Adam's lessons to heart and activate them in all of our communities. And that's really where all of you come in. Please share our resources. Please talk to those other people. Please let us know how we can support you in your organizing work so that we can all work together. Really, to Mary's point, it's about collective action and our collective intelligence and how much we are able to do if we put all of those things together. So thank you so much for being here tonight. And thanks to all of you and to all of our People CDC members who are in the audience.
Thank you.